Suresh, a number of other tyrosine kinase inhibitors have been used either in clinical studies or more anecdotally for management of refractory GIST. Depending on when the other drugs were developed, some of these were in the second or third line setting, or certainly in the fourth line setting. I was wondering if you could comment a little bit on what's been described, as well as your own experience with the use of these medicines. So this would include dasatinib, nilotinib, pazopanib, and sorafenib as examples.
Sure. So I think it would be most appropriate to start this answer by clarifying it to the audience that the standard of care, as long as possible in the second and beyond line settings, should be a clinical trial if available. That sort of admits to what we have already talked about, the limitations of the currently available agents despite their approval and regulatory availability. When clinical trials are not available, or a given patient is not eligible, or they cannot make it to a place where the trial is available, it has been an important and acknowledged fact that keeping these patients on a kinase inhibitor is always helpful, as opposed to leaving them off a kinase inhibitor. I have frequently tried to explain it to patients and even our oncology colleagues that while it's totally unconventional for us to go back to the same chemotherapy after chemotherapy hasn't worked for a given tumor, pick one. This is one where re-challenges with some of the same agents has been standard of care or has been a practice. And sometimes, rather than re-challenging with the same agents, we would use an analog, if you will. So imatinib's analog is nilotinib. We have had dasatinib as a SRC inhibitor available. Sorafenib and pazopanib have been out there as VEGF inhibitors. There are single-arm trials or retrospective series of experiences that have been presented and even published with all of these agents. In the interest of time, if I can summarize and lump all of them together, I think a fair statement is that dasatinib, nilotinib, sorafenib, pazopanib, these agents, when tried in the third, fourth line, well, fourth and beyond line setting, if you will, probably help maybe 1 out of 5 patients for maybe an average of, I would say, median of about 2 to 3 months. As you pointed out earlier, we all have anecdotes who benefited a lot longer, and there are ones who don't benefit at all. So these drugs were felt to have some proof of principle activity. And I think mechanistically, it's not too hard to understand because some of the cells are still addicted to the same kinase pathways, and inhibiting that certainly helps the tumor. It may progress at, as I use a car analogy, at 30 to 40 miles an hour, as opposed to off a kinase inhibitor, the tumor may move at 50, 60 miles an hour. And that faster rate of progression clearly causes more symptoms and difficulty in management and quality of life. So I think these agents have had some activity, but clearly not enough for them to go through an indication or a registrational trial. The toxicity profile of all of these agents run through the same issues that the second and third line therapy go through. In fact, in some ways worse, because typically the tumor bulk is more. And so there are more abdominal and tumor-related symptoms. The response rates with this are typically relatively low, under the 10% cutoff number, if you will. And so between the low response rate, relatively modest clinical benefit rate, none of these could be considered standard of care, which again weighs into the fact that we needed newer agents that we are now blessed to have that can certainly help us treat a patient for a little longer.
Yeah, absolutely agree, and would add, as you mentioned earlier, the availability of clinical trials for eligible patients as well is a great approach to trying to find newer therapies for individual patients, but as well as to move the field forward and learn more about how we can treat this disease.